Hello, and welcome to our program, Overcoming Disease Recurrence and Treatment Resistance in HER2-positive metastatic tumors, clinical manifestations of HER2/3 targeting in gastrointestinal, lung, and breast cancers. If you've not already done so, please complete the program pre-test. I'm Dr. Michael Pishvaian. I'm a GI oncologist at Johns Hopkins University School of Medicine, and I'm joined today by an esteemed faculty, starting with Dr. Minetta Liu, who is a professor of oncology at Mayo Clinic in Rochester. She's also the research chair of the Department of Oncology, amongst other titles. I also have Dr. Estelamari Rodriguez, who is a co-director of the thoracic program and assistant professor of clinical medicine in medical oncology at the Sylvester Comprehensive Cancer Center in Miami. And from Europe, Dr. Benedikt Westphalen, who is the medical lead of precision oncology in the Department of Hematology Oncology at Ludwig Maximilian University of Munich in Munich, Germany. So thank you all for joining us, and the faculty's disclosures will be displayed on the screen. So tonight, we're going to go through a discussion about HER2, HER3 as targets for different cancer therapy, and the objectives will be to describe the bidirectional contribution of HER2/3 as prominent pathobiological drivers of treatment-resistant subtypes in gastrointestinal, lung, and breast cancers, examine guideline-recommended HER2 testing for patients with breast cancer, gastrointestinal cancers, and lung cancer, and to elucidate the mechanisms of action and clinical trial findings of recently approved and emerging HER2 and 3 targeted drugs for multiple tumor types. So before I go into the discussion of the clinical aspects of HER2 targeting, I'm going to give a brief background on HER2 as a therapeutic target in oncology. So we'll start with the first slide. It's been known for decades that the HER family of receptor tyrosine kinases, which function by receptor dimerization and downstream signaling, are critical for the genesis and the growth and progression of multiple different cancer types. And in fact, HER2 which is frequently altered in cancer, is actually one of the few targetable molecular drivers of a more aggressive cancer phenotype. HER2 alterations are mostly marked by overexpression at the protein level due to gene amplification, but we also realize that some percentage of tumors also will have HER2 activity through constitutively active genetic mutations. Next slide. So as I mentioned, HER2 alterations occur in multiple cancer types, and really you can see HER2 overexpressed tumors of virtually any type, but of course with certain cancer types, they occur at a higher percentage. Breast cancer really led the way with the HER2 being a target, and about 25% of all breast cancers have HER2 overexpression. In gastric and gastroesophageal cancers, you see about 20 to 30% overexpression. In colorectal cancer, it's only about 5%, but colorectal cancer is a very common disease. And in non-small cell lung cancer, you can see a percentage of tumors that have both HER2 overexpression, but also HER2 gene activation. Next slide. HER2-driven tumors do tend to have a worse prognosis. A lot of this is from data that's being done in the context of controlled arms of trials as well as older data. But we know that HER2 overexpression in non-small cell lung cancer and gastric cancer definitely confer a worse survival. And in breast cancer, this has been very well teased out, where just HER2 overexpression in and of itself is a clear, poor prognostic factor. Next slide. And you see this in the manifestation of a more aggressive phenotype, where patients that have tumors that have HER2 overexpression, these tumors are really being driven by the HER2 activity, and these tumors have a higher risk of disease recurrence and the development of metastases. And really, in the more advanced patients, the presence of HER2 amplification or HER2 overexpression leads to a median progression-free survival that's really only measured in the 2 to 4 month range for most cancer subtypes. So with that, I'm going to pass things on to Dr. Rodriguez to discuss biomarker testing, treatment options, and especially the mechanism of action of the different treatments that we have. Dr. Rodriguez?
Thank you, Dr. Pishvaian. So I think it is important to discuss how, for the different tumors that we're discussing this evening, GI, breast, and lung, there are different recommendations for biomarker testing. So next slide. So in breast cancer, where we have used HER2 testing the longest, we have well-established guidelines that are standardized from ASCO and CAP that really recommend first starting with immunohistochemistry with reflex testing, for any equivocal results that are 2+ with in situ hybridization. And this is something that pathologists have gotten experience, and we have really been able to get a more standard testing throughout. In gastric cancers, the recommendations are to start with immunohistochemistry or FISH, but when the tissue is limited, it is important to keep looking, and NGS is recommended for patients, especially in the metastatic setting. IHC scoring criteria may also differ from surgical and biopsy specimens, which is something that is not really seen as much in breast cancer. So that is important to note. And in lung cancer, which is really kind of later to the party of HER2 testing and treatments, the testing right now is recommended as part of a broad NGS panel that really looks for all kinds of rare mutations. It's really not a standalone assay with immunohistochemistry that is recommended at diagnosis. There is currently insufficient evidence to support the use of cell-free circulating DNA for the identification of HER2 mutations in lung cancer. Although it can be seen, it's not the only test that you should do. Next slide. Now, in terms of the mechanism of actions of different targeted agents, so we are very familiar with anti-HER2 antibodies like trastuzumab that will bind the receptor and lead to signal suppression. Pertuzumab, which is also used in breast cancer, would inhibit dimerization of the receptor and downstream signaling. But what we're very excited about is the antibody drug conjugates therapy that have come in the market, and they allow for intracellular cytotoxic drug delivery. So you're really targeting the receptor through your antibody, but really introducing chemotherapy. So this is a chemotherapy option. And then the tyrosine kinase inhibitors, we have several that have been tested and some approved for the cancers we're discussing today. Neratinib, tucatinib are some of those, and they inhibit the tyrosine kinase activity. And it's a small molecule tyrosine kinase inhibitor that may have increased activity in the brain. Next slide. Now, here are some of the novel HER2 targeted agents that we will be discussing today. So trastuzumab emtansine is an antibody drug conjugate of cytotoxic anti-HER2 antibody with a payload that is the cytotoxic microtubule assembly inhibitor. And this has been FDA approved for metastatic breast cancer as far back as 2013 based on the Emilia trial, and we'll get more details about that later. We also have data in the adjuvant setting for early stage breast cancer approved in 2019 for patients that have not achieved a complete pathologic response after neoadjuvant therapy with HER2 therapy, and that is based on the Catherine trial. Trastuzumab deruxtecan is another antibody drug conjugate of cytotoxic anti-HER2 antibody with a different payload, being topoisomerase 1 inhibitor, and it has granted isolated approval for metastatic breast cancer in 2019, and also approval for locally advanced and metastatic gastric cancers and GE junction tumors. And that's based on the Destiny gastric trial that we also will hear about later today. Mirgatuximab is a different agent. It's a chimeric FC engineered immune activated anti-HER2 antibody that it was really developed to increase the efficacy and the duration of treatment of trastuzumab. It has been approved in combination with chemotherapy in metastatic breast cancer based on the SOPHIA trial. Tucatinib is one of the small molecule tyrosine kinase inhibitors that we mentioned earlier, and it's a very highly selective inhibitor for HER2, approved currently for metastatic breast cancer based on the HER-CLIMB trial. And then another novel agent is RX-788, which is an anti-HER2 antibody drug conjugate that is different in the sense that it uses a unique non-natural amino acid enabled conjugation, and it has a non-cleavable amberstatin drug linker. So this is not yet approved, it doesn't have a real name, but it's based on some data that we have seen from the A-SPAN Tumor02 trial. Next slide.
Rodriguez for that summary. And, it really brings up the idea that there's some interesting approaches for being able to target HER2. Let's talk really quickly about testing, though, first. And Dr. Liu, I'm going to pick on you. I'm wondering with the NGS testing that a lot of us are doing with our advanced cancer patients, and maybe we're not doing as much IHC, have you found discordance between IHC results and NGS results in your breast cancer patients?
So, I mean, from the NGS perspective, we're looking for HER2 activating mutations. Typically, some of them will look at HER2 amplification. And you will see discordances on occasion with immunohistochemistry on tissue. So that is still the gold standard. Next generation sequencing for breast or lung or other cancers can be used when there is no tissue available. Certainly a good fallback.
And Dr. Rodriguez, for lung cancer, obviously NGS testing is so critical for all the various mutations that are seen. But do you now have cause to do IHC testing as well?
I think it is important to note that in lung cancer specifically, the clinical pattern for mutations can be very different than amplifications. So that in mutations, you're looking for the non-smoker, a lot of adenocarcinomas, and these patients will be very different than the patients that have amplification, where you're looking. Some of the patients that have failed EGFR therapy, they develop a kind of a resistant pathway of HER2 amplification. So those are the settings where you will look for HER2 amplification when we really look for HER2 mutation in all comers. So there are different types of patients.
Gotcha. And Dr. Westphalen, I'm going to ask you a question that there may not be an answer to, but I'm just curious for you to wax scientific on this. You know, antibody drug conjugates have been around for a while, and unfortunately, especially in GI cancer, there's been quite a history of failure of the ADCs. Why do you think that these ADCs that we're going to be talking about today seem to be working, fortunately, for these HER2 positive patients?
Yeah, I mean, most probably we've discussed this a lot. So there are two different answers, at least from a scientific point of view. The first one being how well your target is actually targeted. Binding of your antibody to your target. We've seen good success even in non-successful drugs like TDM1. And then the second is, in my opinion, delivery of the payload, and if you have the right payload being delivered. So, I mean, most probably it was a surprise that TDM1 was failing in gastric cancer compared to paclitaxel. When you now look at the trastuzumab deruxtecan, which really delivers fantastic results. So I believe it's a combination of binding your target and then having the right payload going in.
Excellent. Well, that sets us up actually to sit and go into a lot of the clinical data. And we're going to start with breast cancer. So Dr. Liu, I'm going to hand it over to you.
Thank you very much. It's a pleasure to be here with everybody today. So at the next slide. So as you can tell from this slide, in breast cancer, we're quite privileged for the 25% or so patients who have HER2 positive breast cancer, and that we have many potential therapies. So according to the NCCN guidelines, with first-line therapy for advanced disease, preferred therapy is pertuzumab and trastuzumab and a taxane, either docetaxel or paclitaxel. In the second line, the preferred regimen is trastuzumab deruxtecan, and third line and beyond, we really don't know the optimal therapy. And although trastuzumab was initially approved decades ago, in fact, we keep finding more and more therapies and have the ability to create novel combinations of HER2-directed therapies with other agents, be they chemotherapy or targeted agents, to further improve outcomes for our patients. Next slide, please. The phase 2, phase 3 trials in HER2-positive breast cancer, the HER2 CLIMB study 04 is looking at tucatinib and trastuzumab deruxtecan. It's a phase 2 study in patients with locally advanced or metastatic HER2-positive breast cancer. And to be clear, these trials are all looking at the traditional HER2-positive breast cancer, either IHC 3+ or FISH amplified. So those with HER2 activating mutations are not included in these trials. The TULIP study is looking at a novel antibody drug conjugate in a phase 3 study, trastuzumab duocarmazine versus lapatinib and capecitabine, or trastuzumab with capecitabine, vinorelbine, or ribulin. And this trial had reported out previously, and progression-free survival was statistically significant in favor of the novel antibody drug conjugate. Overall survival remains to be seen. The adverse events most commonly observed here are conjunctivitis, keratitis, and fatigue. Next slide, please. Several phase 3 trials are ongoing or have recently reported out. Destiny Breast 03, trastuzumab deruxtecan versus trastuzumab TDM1. There was an advantage to trastuzumab deruxtecan over TDM1, 14.3 versus 6.9 months. That was statistically significant. Very importantly, as you look at these different HER2-directed agents, we have to be very mindful of the toxicities. Where we're used to trastuzumab, which was very well tolerated, there are unique toxicities, particularly with the antibody-drug conjugates. Here we have to be mindful of the potential for interstitial lung disease in particular, which, although uncommon, can certainly happen. The SOPHIA trial reported out with margetuximab and chemotherapy versus trastuzumab and chemotherapy, demonstrating a benefit in responses and clinical benefit rate with margetuximab and chemotherapy. Here there were potential infusion-related reactions and left ventricular dysfunction, but nothing out of the ordinary versus trastuzumab. Next slide, please. A number of other trials for which we're waiting results: DESTINY-Breast02, trastuzumab versus capecitabine with trastuzumab or lapatinib, HER2-CLIMB-02, which is TDM1 plus or minus tucatinib in locally advanced or metastatic breast cancer, and even in early stage disease, COMPASS HER2, RD, or residual disease is looking at TDM1 with or without tucatinib in patients with high-risk non-metastatic HER2-positive breast cancer who've received prior neoadjuvant chemotherapy. Next slide, please. There's a new area arising within breast cancer, which is the HER2-low type of breast cancer. So not the traditional HER2 positive. This is defined as low HER2 expression, which is now emerging as a biomarker for novel therapeutics. It's not prognostic, but it does potentially predict benefit from some of our HER2-directed therapies. HER2 low is defined as immunohistochemistry negative but 1+, or equivocal at IHC 2+, and FISH negative. So there's slightly increased ERBB2 expression in these cases. And patients who have HER2 low tumors don't benefit from trastuzumab, but they do appear to benefit from some of our emerging HER2-directed antibody drug conjugates. And you can see that the expression of ERBB2 relative to HER2 status in the table at the bottom left. And it's differentiated between hormone receptor positive versus hormone receptor negative. And in the pie chart on your right are the estimated percentages of cases by HER2 expression that include traditional HER2 positive, the HER2 low, and then the HER2 negative. Next slide. And there have been, again, studies demonstrating potential benefit to the antibody drug conjugates in the HER2 low breast cancers. So on your left versus on your right, as you can see, changes in tumor size from on your left is trastuzumab deruxtecan, and on your right, trastuzumab duocarmazine. And you can see that the HER2 low, whether it's hormone receptor positive or hormone receptor negative disease, there are a significant number of patients who do have a change in tumor size from baseline. Next slide. I'll hand it back over to you, Dr. Pishvaian.
That was great. You know, there really has been such a massive amount of data in HER2-positive breast cancer for decades now, and it's teaching all of us and the other cancer types a lot. And to that end, actually, I'm going to ask you, Dr. Liu, you know, this is not meant to be an algorithmic or cookbook question, but how in the world do you go about thinking about sequencing HER2-targeted therapy for your advanced breast cancer patient?
Yeah, once we get to third-line therapy, there are so many options, and it really does come down to prior treatment response, what therapies they benefited from, and also what their medical comorbidities are. Again, we can't stress enough the potential risks for interstitial lung disease, although rare, is very real. And so it comes down to those careful considerations. Right. There are also lifestyle issues, oral therapies versus IV therapies.
And then you talked about the HER2 low breast cancer patients. What kind of percentages are we talking about that they're adding to that 25% of traditional HER2 overexpressed? How many more percentage points are HER2 low? And before you answer that, are there HER2 high patients who are being converted to HER2 low later in their disease?
Well, certainly we see as we do more and more serial biopsies from primaries to initial presentation of metastatic disease, or even follow-up biopsies of metastatic disease, HER2 status can shift over time. And so repeating HER2 status whenever you're doing a biopsy is, I think, critical. In terms of the number of patients who may benefit from HER2-directed therapies, if we include the HER2 low, it could in fact double the proportion of patients who might benefit. Although, again, we're not thinking about trastuzumab when we're thinking about HER2 low. It's really those antibody-drug conjugates specifically.
Excellent. Again, a lot for us to learn from breast cancer. So going on to gastrointestinal cancers, Dr. Westphalen, you want to lead us through all of the data that's really emerging in this disease group?
Yeah, my pleasure. Again, hello everyone from Europe. My name is Benedikt Westphalen. Next slide, please. So in GI cancers, what breast cancer has been, we have to say that gastric and esophageal cancer has paved the way for HER2 targeting, and in HER2 positive GI cancers, gastric esophageal cancers, trastuzumab plus chemotherapy is standard of care. And then based on very, very convincing data, we have a second-line preferred option with trastuzumab deruxtecan. Next slide, please. And there are very, very interesting and pivotal trials now in the phase 2 setting going on. Firstly, the combination of trastuzumab and pembrolizumab, which then paved the way to the Keynote 811 study and approval of this combination in gastric cancer. And then we see the gastric 01 study with trastuzumab deruxtecan versus chemotherapy in pre-treated gastric cancer, which has been treated with also trastuzumab, where you see really significant improval of overall survival in a so-called chemo-free surrounding. And what I have to say, and stressing the point of interstitial lung disease, although uncommon, here we see 10% of patients in the gastric 01 study, it can also happen very early. We had one patient hospitalized just last week where we had no idea why he was doing so poorly after just one cycle of trastuzumab deruxtecan, and the lung really looked awful on CT, and also lung function tests were really bad. And the young fellows on the ward were surprised that such a thing could happen with just one cycle of the therapy. So really keep that in mind. Next slide, please. And then there is a lot of interesting studies now going on, really in pushing these novel compounds into phase 3. Not surprisingly, with ramucirumab paclitaxel as being an established second-line option, trastuzumab deruxtecan is tested against this second-line regimen. Then you have in the Mountaineer trial, again, RAMPAC against tucatinib and trastuzumab. And what I find interesting about Mountaineer 2, and it will really be interesting to see the results here, tucatinib has an impact on paclitaxel metabolism. So there is actually a dose finding in that trial. And teasing that out when we look at the final results will be very interesting, because we have seen trials where your standard of care chemotherapy was underdosed for various reasons. So let's see how that pans out. And then you have rituximab and chemotherapy plus advanced immunotherapy as a combination in the Mahogany trial. This is going to be really interesting to have so many different agents with so many different modes of action, especially novel DART immunotherapeutics in gastric cancer. Slide, please. An area where we've seen HER2 targeting for quite some time is colorectal cancer. Next slide. And what is surprising is when you look at the NCCN guidelines, you would say that these patients undergo standard of care chemotherapy unless they're non-fit for combinational therapies. Then you can go into HER2 targeted therapies. What is important, and we've learned that the hard way, especially from the My Pathway study that we'll show in a second, is that this is mainly or only effective in patients with RAS wild-type colorectal cancer. From a molecular standpoint, not very surprising, but still we had to learn that during conducting these pivotal trials. Next slide, please. And those trials that really paved the way, Heracles and My Pathway, they're quite old, and those are phase 2 clinical trials that really paved the way to have HER2 targeting in the NCC guidelines. We are a little bit less open to have these in guidelines in Europe. It's mentioned and it's an option, but since this is only phase 2 data, we're really looking forward to more comprehensive trials coming in the future, following up on trastuzumab, pertuzumab, or trastuzumab lapatinib. And there's very interesting data for trastuzumab tucatinib that has been presented within the Mountaineer trial with 22 patients with an overall response rate of 55% and a median progression-free survival of 6.2 months after progression on 2 lines of chemotherapy. And then trastuzumab deruxtecan, as seen in the Destiny CRC01 trial, again with a very interesting overall response rate of 45% and a median progression-free survival of almost 7 months, again in heavily pretreated colorectal cancer. So really exciting to see these new compounds coming into play. Next slide, please. As a precision oncologist, biliary tract cancer is really close to my heart because what lung cancer is to oncology, overall biliary tract cancers is what we see an emerging entity in precision oncology and GI cancers. Next slide, please. And the HER2 positive biliary tract cancers, and this is specific. Usually when we talk precision oncology in biliary tract cancers, we mainly focus on intrahepatic cholangiocarcinoma. For HER2, it's the opposite. We see it mostly up to 15% in gallbladder cancers, and the same numbers up to 20% in extrahepatic cholangiocarcinoma, and very, very little expression in ICC. Interestingly, in the NCCN guideline, there is no mentioning of HER2 targeted agents, but the data that we'll discuss in a second is quite new, so I figure it will be in guidelines quite soon. Next slide, please. Because what we saw in the My Pathway study with almost 40 patients treated with the combination of trastuzumab and pertuzumab, we saw an overall response rate in heavily pretreated biliary tract cancers of 23%, which is not that great to start with. But then looking at the sheer numbers, up to 20% of your patients, and then a median duration of response in a completely chemo-free setting of 10.8 months. If you consider that that's the overall survival that we would see in patients that you treat with gemcitabine cisplatin and then follow-up regimens, this is really amazing. So a really big chance for our patients with biliary tract cancer. Next slide, please. And while we have very, very promising and large clinical trials in other GI cancers, for biliary tract cancers, the landscape, it being a rare cancer, is a little bit less wide. We see, not surprisingly, tucatinib and trastuzumab in a small basket trial, and a new drug, ZW25 or zanitinib, in a bigger trial in HER2 positive biliary tract cancers in the second line treatment, where I see a good option to have these drugs come into play. Next slide, please. And that was it from my side.
That's a lot to cover.
Yes.
A lot to cover. Thank you so much, Dr. Westphalen. Really, this is an emerging area, HER2 treatment in gastrointestinal cancers. And as Dr. Westphalen showed us, there's a lot to really digest, and actually a lot of exciting new trials that are opening up. Just to talk about these GI cancers for a second, actually, I'm going to pose this question to Dr. Rodriguez as somebody who's probably more used to using immunotherapy than the rest of us. There's really incredible data that Dr. Janjigian published of trastuzumab and pembrolizumab. Am I remembering that correctly? In HER2 positive gastroesophageal cancers, but at this and there seems to be some synergy between HER2 targeted antibodies and the PD-1 checkpoint inhibitor. But the same kind of response is not seen with cetuximab and pembrolizumab. There was a recent colorectal cancer trial that was published, and there was really no benefit to the IO EGFR antibody combination. So, just as an immunotherapy expert, what's your thought process on why it worked with a HER2 antibody but not a HER1 antibody?
That is a great question, and I, usually tell patients that when, for example, for EGFR mutations, if that is the single driver mutation, the immunotherapy response is really not going to augment that type of response. And what we have seen is that as a single agent immunotherapy in EGFR, there's really no activity. And when you add chemotherapy to it, we have one trial in Power 150 that added immunotherapy to chemo, but really all we see is more toxicity, I think, for the most part. I think HER2, the HER2 story is very different because what we're delivering is chemotherapy with or without immunotherapy if you have a combination. And we have an ongoing large trial, international trial, that is going to look at the combination of some of these antibody drug conjugates with immunotherapy. And I think we might see a difference. We may see more toxicity. We worry about interstitial lung disease because you could potentially potentiate an pneumonitis with a different type of immune toxicity related to the antibody drug conjugate. But the trials need to be done so that we can really understand how these two drugs can be delivered safely. But I think they're different, just different percent. At least in lung cancer, we definitely see a different activity based on the fact that the mutation, the immunotherapy is triggering a response to one mutation or many mutations. So it depends where EGFR exists next to HER2 therapy.
Great, thank you. Dr. Liu, I'm going to ask you a question about, again, sort of another waxing scientific question. So in colorectal cancer, trastuzumab was tried with chemotherapy, and it really didn't achieve much of a goal. And the MyPathway data with the dual antibodies seemed promising, but really the benefit seems to be most promising when there's dual HER2 targeted therapy with an antibody plus a small molecule inhibitor, a tyrosine kinase inhibitor. And I know some of those trials were done in the past with breast cancer with like trastuzumab and lapatinib. But why would you think that certain cancers only respond by hitting the extracellular portion and the intracellular portion concurrently?
I don't know if anyone can truly answer why yet. I think the key is that in different malignancies, tumor types, that combinations of HER2-directed therapy, be they monoclonal antibodies or the tyrosine kinase inhibitors, or with chemotherapy, again, monoclonal antibodies or tyrosine kinase inhibitors can separately be combined with chemotherapy or even other targeted agents. And this, I think, all speaks to the need for better biomarkers just beyond HER2 testing for us to be able to better identify what the best pairing is for these patients.
Absolutely true. And then Dr. Westphalen, Dr. Liu talked a lot about the HER2 low expressing breast cancers, but are there data emerging in perhaps like upper GI cancers of targeting HER2 low cancers?
You caught me there. So I'm not sure. I haven't seen any data that really supports this notion of targeting these cancers. To dodge the question a little bit, what I would find really interesting here is if we're able to convert these low expressors to higher expressors, as we've seen in other disease areas, thyroid cancer, where we re-differentiate after a loss of hormone receptors, for example. So really, that would be an interesting area to explore, but I haven't seen really good data on low expressing GI cancers with good activity. But with the new, especially with the new antibody conjugates, I feel that this is an area where we at least should look at.
Yeah, no, and I definitely didn't catch you there, because if you don't know, I certainly don't know. So moving on to lung cancers, our last section, Dr. Rodriguez, I know there's a lot to learn in this disease type as well.
Thank you so much. So there is definitely a lot on the horizon for HER2 lung cancer. So although that really translates to about 2 to 4% of all the lung cancers we've seen, we know in lung cancer that is such a common cancer that this is a significant amount of patients. So there's a lot of research, a lot of new exciting trials that will read out in the next coming years. So I'm going to first start, next slide, going over the NCCN guidelines to see where HER2 testing as an emerging biomarker fits in. So currently, the recommended therapies that are listed right now are both antibody drug conjugates, trastuzumab emtansine and trastuzumab deruxtecan. If you remember, there was a prior 2018 version of the NCCN guidelines that had a tyrosine kinase inhibitor, but I think these agents have really shown higher activity. So they at least trastuzumab deruxtecan has FDA designation for breakthrough designation. So it's an agent that is really part of our options for patients. It's important to recognize these patients, and we know that in lung cancer, the biggest challenge for the treatment of these patients is that if they don't get tested, if you don't look, you're not going to find the mutation. So we need to recognize that this is a driver event and that there's options for these patients. Next slide. So I'll go over first the clinical data that we have so far. So we have phase 2 trials in HER2 lung cancer that have shown activity, mostly with antibody drug conjugates that really surpass what we had seen in the past with other tyrosine kinase inhibitors. So the basket trial with trastuzumab emtansine included 18 patients that were ERBB2 mutant that had 0 to 4 prior therapies. And you have to understand that these are patients that have previously failed chemotherapy. Some of these previously have failed immunotherapy, like in the Destiny Lung trial, and you really didn't have any further options. And in this group of patients, we were able to see an overall response of 44%, with a median duration of response of 4 months and a median progression-free survival of 5 months. And the toxicities of these agents, because they're truly delivering chemotherapy through the payload, are really toxicities that we know how to manage in the sense of cytopenias, fatigue. There were some notable infusion reactions, weight loss, and some rash that was noted on this trial, this phase 2 trial. Now, the larger experience that we have with antibody drug conjugates comes from the Destiny Lung 1 trial that we first heard about during ASCO 2020 virtually, and it was just published a month ago in the New England Journal. So this trial had many arms. They were patients that had HER2 overexpression and amplification, but the data that was presented that showed the best efficacy was truly for the HER2 mutant lung cancers. And these are patients that also had refractory to prior therapy. Many of these patients had prior chemo and immunotherapy. And in this group of patients, we saw an overall response rate of 55%, which is really impressive for patients that already are in third and fourth line. With a duration of clinical response of 92%. So this is a very durable response for these patients. The median progression-free survival was around 8.2 months. With patients that were really on later lines of therapy, we hadn't seen this. And the median overall survival was 17.8 months, which really got people excited. So the adverse reactions to note, again, very similar. The more common ones relate to the chemotherapy, toxicity of neutropenia, anemia, some diarrhea, and decreased appetite. And those we know how to manage. I think what really got our attention that has been mentioned previously was really some of the toxicity relating to interstitial lung disease, and there were 2 toxic deaths in this trial, which would translate to 1 of 50 people that you treat may be at risk. Now, that was with a higher dose, and they're currently testing lower doses of the drug, but it is important to recognize this pneumonitis as a potential toxicity. Most of these were low grade and well managed with steroids. So I have treated patients that we have managed with steroids. So, and in this trial, they were able to show that most of this toxicity resolved for patients. So it's something that we have to learn to recognize early and manage. But the toxicities that led to dose reduction were more fatigue. The Destiny Lung 2 trial we will see coming up is really testing that lower dose of the agent, and hopefully we'll see less toxicity and same efficacy. And the next slide, upcoming trial is a larger phase 3 trial, which will compare first line trastuzumab deruxtecan versus the standard care of platinum pemetrexed with pembrolizumab. So this is going to be a larger trial with 264 patients who are first-line ERBB2 mutant, exon 19 or 20. And we look forward to that because the question is if this is truly a targeted therapy. Really, our current standard right now for targeted therapies in lung cancer is really to treat the target first before chemotherapy and immunotherapy. So this trial will let us know if that applies to HER2 therapy as well. Next slide. Now, I will discuss briefly HER2 and 3 in salivary cancer. So we know salivary cancers are even more rare. So they're about 0.7% of all cancers. And really they don't have great responses to systemic chemotherapy. So I think it is really important to recognize that HER2 has a activity for patients that have HER2 overexpression. So we have data from the MITE pathway trial, which is a basket trial that included 19 patients with salivary gland carcinoma with a combination of trastuzumab and pertuzumab, and there were 15 patients. Most of them are overexpression. There was one patient with mutation, and the overall response rate was very impressive at 60%, also seeing very durable responses of 9.2 months and median overall survival of 20.4 months, which is really something very notable for a tumor that doesn't really have a lot of systemic options. And the toxicity, again, relates to cytopenias from treatment, and there were other toxicities related to GI, infusion reactions, fatigue, and abdominal pain. So really exciting and more research to be presented for salivary gland carcinomas. Next slide.
Thank you, Dr. Rodriguez. That was a great summary of the lung cancer data. And actually, let me ask you one question that I posed to Dr. Liu earlier. Now that HER2 options are available for lung cancer, how would you sequence an advanced lung cancer patient that has HER2 positive disease?
So based on the data that we have today, it is really a second-line option. And it's important to know that even patients that had prior immunotherapy were able to tolerate this agent well in that trial, and they responded well. Now, there were 1 or 2 patients in that trial that had it first line. And I think we really need to get a larger trial, which would be Destiny 4 trial, will really answer the question if it's really better than first-line therapy for patients.
Very good. And for anyone for the group overall, I think that as we expand our HER2 repertoire, do you know of any, or are you aware of any other antibody drug conjugates that are using alternative therapies as the payload that may have a different range of approach for some of these patients? Dr. Liu, are there other breast cancer targeted therapies that you know of that you can think of that you can speak to publicly that you know of that may have different payloads?
Not that we can comment on, I think, here.
Okay, fair enough. Dr. Westphalen?
Yes, same. So, I mean, there's a lot of data that I've seen preclinically where I believe, and this is going to be key, I believe that we in the future are able to deliver a payload that is then fitted to your respective disease. So in the beginning, when we looked at TDM1 failing in colorectal cancer, most people said it was not only because the drug was shuttled out of the cancer cells quite soon, but it was also because the payload is really not working as a classic chemotherapeutic agent in colorectal cancer. So this is really where I get excited if we are able to couple more and more common old chemotherapeutic drugs to these targeting agents then.
Fantastic. Well, this was an enormous amount of data for all of you to go through, and I'm going to try and give you a little bit of a summary as best I can, but really my summary would be to suggest that you go back and listen to the talk. But really, HER2 targeted therapy is important because it is a useful target. It's becoming a target across multiple different cancer types, as we've highlighted here today. In all of the cancer types, immunohistochemistry is important to look for overexpression. NGS also is a way to be able to capture some of the gene amplifications as well as those constitutively active mutations. Guideline recommended treatments, I'm not going to go through each of these, just to say that overall they are becoming part of the guidelines in multiple disease types, and we really have to consider these HER2 targeted therapies. I think that the data for HER2 low breast cancer is fascinating, and I didn't realize the number, Dr. Liu, thank you, that it may add another 25%, 50% more patients that could be potentially treated with HER2 targeted therapy, despite having HER2 low expression. And so this may be, again, another area that opens up other treatment options for other cancers as well. And there are multiple different emerging therapies, including multiple combinations that could be envisioned and are actively being tested now. So this is really just the beginning of this era, even though this era started, in the early 1990s, if I'm not mistaken. So thank you all to the faculty for giving your time, for sharing your expertise, for getting up at 2:00 in the morning and drinking a cup of coffee. It really was an exceptional talk. You all are experts in your field, and we appreciate you for sharing your time. And thank you to your audience as well for joining us today. Please be sure to claim your CME credits by completing the post-test and evaluation form at www.integrityce.com/TBT eval 2. It's actually pretty easy. It takes just a few minutes. And we look forward to seeing you again at the next webinar. Thanks so much.